Well, thank you very much, Brian, for that very kind introduction. At the end of my talk, you might still be wondering about my curiosity, because I'm very curious too. I'm starting out with a question, and I'm going to end with some questions. The title of my talk is Challenges in Antibody Measurement. If clinical immunologists can't be chemists, should they be population biologists? These are some disclosures. The goals today are to understand some of the challenges of standardization and harmonization of the ANA test, an example and an important example of an antibody test, present the concept of population-based harmonization and calibration of tests, and then try to extend some of those concepts of population-based harmonization to assays for SARS-CoV-2 antibodies. A lot of what I'm presenting today is really thoughts and works in progress, so I'm interested in feedback along the way. But let me start with talking about the ANA, one of the important tests for clinical rheumatologists and for a clinical clinical immunology laboratory. Several years ago, based on recommendations from the American College of Rheumatology, the immunofluorescence ANA test was designated as the gold standard for ANA testing. And I want to talk about what are gold standards and what that might mean. So can we standardize a gold standard? And is the gold standard actually 24 karat gold and really weighty? Or is it fool's gold? Or is it really kind of a pipe dream? And all those issues come in play when we're talking about certain laboratory tests. I want to start out by really describing the test. I think most of you know about it. There are glass slides in the clinical laboratory on which have been grown a cell line called the HEP2 cell, and that's the substrate for antibody binding. If you look under the microscope, one would see this cartoon kind of thing, that multiple antigens within the cell, depicted here by different shapes and colors. If the patient has a serum antibody that's directed against one of those antigens, as shown in this orange color, it'll bind. And then one detects that with a fluorescinated anti-human IgG, look in a fluorescence microscope, and the result comes back as a pattern and a semi-quantitative titer. And this is sort of the classic kind of patterns that one might see under the microscope and described by how they look under the microscope. Homogeneous, this is staining the nucleoli of the cell, a speckled pattern, and the centromere. So that number of identified patterns has grown over the last few years, and there are now 29 defined autoantibody patterns. You can read about them at the website, anapatterns.org. And this is work done by the International Consensus on ANAs, the ICAP. So this has improved, if you will, immunofluorescence staining in some respects. Pattern descriptions and associations have been clarified. Pattern reporting is becoming more systematic in the field. But titer, the titer result, which is a semi-quantitative result, really there's been no systematic approach, and I would say no real improvement. And this is sort of what one sees under the microscope and kind of what the problem is. Typically, one dilutes the serum at a starting dilution. For example, 1 to 40 dilution of serum is common. If one stains the slides, one sees more intense staining with serial dilution, twofold dilution, 1 to 80, 1 to 160, 1 to 320. The immunofluorescence intensity decreases, and the report is the highest dilution that's a positive result. So in this case, this would be diluted 1 to 160, negative here at a 1 to 320 dilution. But you can imagine and see what the problem is. Clearly when it's very bright, that's clear. And clearly when there's no immunofluorescence, that's clear. But what about in the middle? Where do we have this quantification? And actually, if you turn off the lights in this room or in Zoomland or wherever you are, you'd see that there actually is some staining here. Turn on the lights and you'd miss a lot of it. And I'm in these glom lights, I can't see anything anyway. I'm sorry, but you can see that there's a pattern of what is this endpoint. And the principles of a clinical laboratory is we want laboratory standardization. Laboratory users expect and deserve laboratory results to be equivalent no matter where and how they are obtained and interpreted in a consistent way. Now, we can't achieve perfection. This is from a review in Clinical Chemistry just in December. Standardization as this kind of temple that we have allegiance to hard to carry it out in real life sometimes. One way to think about this is the way one thinks about target shooting, and this is an example that's often used to depict some of the issues where we talk about accuracy and precision, where the target here in red and all the shots basically cluster very closely around that target. So this would be an assay that's considered to be both accurate and precise. Here's one that clusters around the target. It's always around it, so it's accurate, but a lot of scatters, so not precise. Here's an example of one that is not accurate. It never actually gets close to the target, but they all cluster together, and then others that are neither accurate nor precise. So this is kind of a standard depiction. But all that depends on a gold standard. You have to know what the target is. So my question is, what do we do when there is no standard? And if all these targets essentially disappear and you're just left with the spots, how do we quantify? How do we measure? And when they all show up together, looking at different methods from different laboratories, sort of this is the picture that we're dealing with, how do we know what's true? So the concept I'm going to present is that we might be able to align assays by their population distribution. So here's an assay that tends to give results that are in the middle. Here's one that tends to give results that are on the high end. Here's one that's tend to be on the low end. The assays have different calibrations, get different results when testing the same or similar population. Can we set up a percentile based on what a population that's similar looks like? For example, 70th percentile sort of depicted here, and then align the different systems so that the targets line up, even though the assays don't directly themselves. So this is harmonization by target population, not by the assay itself. Why is this important? Well, an ANA test is important for a number of autoimmune rheumatic diseases, where the sensitivity is expected to be about 95% in lupus, high in other related connective tissue and autoimmune diseases, and these play a key role. So autoimmune rheumatic diseases are often challenging to diagnose, and they're also high-risk diagnoses. Treatment is often involving immunosuppression, often chronically. Missed diagnoses may lead to delayed or mistreatment, incorrect treatment. And although I'm going to tell you that the ANA test is imperfect, it's really essential to some diagnoses and disease classification. And kind of the bigger picture is many patients, huge number of population, have musculoskeletal and arthritic symptoms. In fact, they are the most common chronic condition in the general population in a number of population surveys. Some of these are inflammatory. Some of these inflammatory diseases actually involve primarily the musculoskeletal system. Some involve many other organs and systems. And the ANA-associated diagnoses kind of cover all these. Some may include musculoskeletal arthritic conditions, and some can focus on other organ systems. And sometimes the only key to the diagnosis, or at least an important one, is the presence of a positive ANA. On the other hand, a negative ANA is important because it has high negative predictive value for lupus and some other diagnoses. Essentially, you can almost rule out lupus if the ANA is negative. At least that's the expectation. So, from a clinician's perspective, the presence or the absence of an ANA is often actually a very key decision point in evaluating a patient. But at the same time, ANA testing in clinical labs has been shown to be variable and unreliable. And here's one provider, a rheumatologist, who sort of talks about patients with diagnosed lupus where you'd expect nearly 100% to be positive. So almost 5% were negative in one kit and over 20% in another kit. And they're basically saying there's too much variability. We expect all these patients essentially to be positive because these are established diagnoses of lupus. Here is a question also about titer. This is from an academic US practice where they sent the same specimen to different laboratories and saying, well, do they agree with that quantification and the titer? And they had various criteria, from stricter criteria for agreement to looser criteria, but whatever criteria they used, less than half agreed between sending the specimens to different laboratories. This is not just a US problem, this is an Italian study. This has been widely reported, but not in a systematic way. So several smaller studies, including the ones that I just showed you, showed reported problems. But we wanted to ask the question, is this common and persistent, or essentially anecdotes from a few laboratories? So we used proficiency survey results to assess this. And I think all of us in the clinical laboratory are familiar with CAP and other proficiency surveys, where the same specimen or aliquots of the same specimen sent to labs all around the country or even around the world and see what results they get. And the primary goal of this is to assess individual laboratories, but it can also be used to evaluate populations of laboratories and see how they perform. And so in the US, as I mentioned, College of American Pathologists, CAP is the major source. And Susan Fink, Dr. Fink in our lab, and Mike Linden at the University of Minnesota, former resident and fellow here, together with CAP personnel, had the opportunity to look at the long-term consistency of ANA titering in the United States. This is a typical result of one specimen where the results, and in black is shown the overall distribution of laboratories in the United States as they reported this single specimen, some as low as 1 to 80, some as high as 1 to 50, 120. All these were positive results, so from the CAP's perspective, they all passed. These are all a passing grade, if you will. But you can see there's wide variation. And you can see that different kits, shown here, kit 1 with a dotted line and kit 2 with a dashed line, the distribution of results from kits from different reagents, different vendors, were somewhat different from each other. And this was actually a very long-term phenomenon. This is over 10 years of studies. And if you rank the ANA titering by different reagents and kits, one reagent kit was always high. Some reagent kits were pretty consistently low over the decade or so, and some kits were mid-range. So this represents over 54,000 individual results in over 65 labs for each sample kit combination. The remarkable thing, actually, I would say, is that the vendors or the kits are actually quite consistent. But there are no guidelines, really, for standardizing. So very little motivation, and they don't change. So this degree of discordance has been present, and really there's no plan to fix it at this point. What about the complaint? Remember from that earlier paper that some labs report positive and some negative for the same specimen? Well, proficiency surveys are really designed to look for consensus. We don't want to have disagreement between labs. We're trying to find those that are either really high or negative and see our labs in general agreeing with each other. So in the CAP proficiency survey, consensus with over 90% agreement is expected and achieved in almost all specimens, because that's the design of proficiency survey. But titer is an indirect measure of whether a specimen is likely to be called positive or negative. And you would predict that if you tend to run high in the titer, you tend to have more false positives. If you tend to run low in a titer, you'd expect to have more false negatives. And when I say false, I mean disagree with the consensus result and the overall expectation. And that is exactly what we observed with the mean ANA kit titer rank over those multiple years and the relative frequency of false positives or false negatives. Methods with the higher titers tended to have more false positives, shown here in red, highly statistically significant. Those with lower titers tended to have more false negatives, if you will. It approached significance but did not achieve it. But this is not a surprise given what we know about how these tests are done. One of the questions is this just an artifact? Proficiency survey material always needs to be stabilized and aliquoted and handled differently. So this is a problem of what's called commutability. The idea is that a survey specimen, or for that matter, a calibrator or a standard, to be valid, it should give equivalent results as clinical specimens done with the same method in the same lab, and that is termed commutability. So in order to assess that, one would have to look at the proficiency survey results and then compare them with clinical results to show equivalence. And we had the opportunity to do that in this publication that Susan Fink evaluated with lupus sera and scleroderma sera that had different rank based on different methods that were run. And the overall titer that we saw in proficiency testing from the CAP matched really almost perfectly with the titer rank for the individual patient specimens in the laboratory. And the probability was highly significant. So this isn't proof of commutability exactly, but it certainly is consistent with it and supports the idea that what we saw in CAP survey material is reflecting of what we see in patients and vice versa. And so again, looking at what we saw, long-term variability, substantial and consistent differences between kits and reagents. This isn't random error, this is consistent differences. But the curves are wide. Individual lab inconsistency goes far beyond just a single kit. At the same time, we think this is commutable, so likely reflects what's happening when our patients get tested. So is this really important? Well, I would say that it is. Consistency in the titer is important for clinical interpretation, as is true for most laboratory tests. The degree of abnormality is a prediction of what's the clinical significance in a given patient and in a population. It's important, as it turns out, in clinical trials, and it's important in epidemiologic classification. And this got even greater intensity of need because in 2019, the American College of Rheumatology, the ACR, and the European equivalent came up with new epidemiologic classification criteria for lupus, and they had an ANA of 1 to 80. A particular single titer was an entry criterion. So this is from that paper that's published, and basically the idea, if the ANA is not positive at greater than or equal to 1 to 80 titer, then they can't qualify as having lupus. And really this is sort of the notion here. If the ANA is positive, go ahead and ask the questions about clinical and laboratory features. But if they don't ask any more questions, you're done. They don't have lupus from an epidemiologic perspective. This isn't really the way clinical diagnosis is done, but it is really related and a reflection of how clinicians often think. So what's the basis for that 1 to 80 titer and how was it done? And this was from a paper in 2018 where they came up with this notion that the ANA of greater than or equal to 1 to 80 would be the useful entry criteria. And this was based on a review of lots of papers over multiple years. You can see even on this alphabetical list going back to 1991 from multiple places around the world. And overall, after screening lots of studies, they found reasonable sensitivity and specificity data from 64 studies, over 13,000 lupus patients, over 7,500 controls, including disease controls and healthy. And that's what led to generation of this receiver operating characteristics curve, or an ROC curve, with sensitivity, as we know, on the y-axis, and as the true positives, the false positives, which is 1 minus specificity on the x-axis, and here's the ROC curve. And ordinarily, when one thinks about an ROC curve, we would choose a cutoff as close as possible to the top left corner. And there's a formula for calculating that, so-called Youdin's index, to maximize sensitivity and specificity. Because of the clinical interest in this group, where they wanted to have a more sensitive test, they said, we're going to pick 1 to 80 to increase the sensitivity, even though that's going to lower the specificity just because of that necessary interchange. So that's what they concluded. And this is a quote: cutoff titer of 1 to 80 by the HEP2 ANA test results in 97.8% sensitivity and what they called acceptable specificity for lupus. Accordingly, we're going to use this for the classification criteria, and this is the conclusion from their paper. Sensitivity of almost 98%, specificity overall of only 75% or so, but that includes disease control patients as well as a healthy population. Now, what's interesting, because just a few years before, an international group of experts basically came up with a recommendation for how to screen ANA, and they basically said, actually don't even bother looking at 1 to 80, start at 1 to 160, because 1 to 80 has too many false positives. So, and in general, they say dilution of 1 to 160 on conventional substrates is often suitable. So individual laboratories are left with uncertain guidance about what to do. Should we screen at 1 to 80, which is the ACR-EULAR classification criteria? Should we screen at 1 to 160, which was this expert group? In the US, the most common screening dilution is 1 to 40. In Europe, the most common screening dilutions are 1 to 160. There is a lot of heterogeneity in the world. And even if you say, all right, we'll pick 1 to 80 because that was in these criteria, what does that mean? It's not standardized. So how do we standardize? At least for this 1 to 80 cut point, which has some, I would say, at least epidemiologic as well as clinical significance. Well, my friend and colleague Andy Hufnagel told me that immunoassays are imperfect many, many years ago. And mass spec is, if not perfect, gets pretty darn close. So I thank you. You didn't say that immunologists are imperfect. You said that immunoassays are imperfect, but there's some of both. So what would a clinical chemist do? And the answer is you make a good standard and find a standard method and a standard approach to determine truth. And there are algorithms for how to do that, starting from primary reference material to secondary reference material, having primary procedures that are essentially the reference method coming from national laboratories, and then working down to secondary and tertiary calibrators, and then the product calibrator that goes into a kit, into a routine lab. And the uncertainty from truth increases, but there's a way to trace it all the way from a primary reference. And this is an example from the CLSI metrological traceability and its implementation, and they use this example for glucose. There's a gold standard material, a gold standard procedure, and you can trace that all the way down to the results in a clinical laboratory and a patient result. What if there's no gold standard? Well, the answer is we're pragmatic. We do the best we can, and at least we try to give equivalent results, and that is called harmonization. So this is a comparison of those two, of standardization versus harmonization. If there's a standard, you can have a standard preparation, a standard approach, standard methods and material and units. And if that also works in clinical laboratory testing, that would really maximize uniformity of test results. And that is sort of the gold standard. But sometimes we can't achieve that. And so we have to harmonize. We adjust for differences and inconsistencies between methods to make them as uniform and as mutually compatible as possible. That requires consensus in reporting and sometimes individual test characteristics. So there are standards for standards, and the International Organization for Standardization, ISO, has this lab test traceability platform. I do get a kick out of the fact the name is International Organization of Standardization, which ought to be iOS, but here are standards, they're calling themselves ISO. Nevertheless, they do define traceability to the highest available reference system component. The jargon here is, if you have a reference method or a certified reference material, use it, but sometimes that's not available. And so are these calibration hierarchies. Diagnostic lab methods need to depend on what's available. And if you don't have these absolute gold standards, you use what you can. And the ISO and Joint Commission on Joint Committee is the name on traceability in lab medicine actually came up with some criteria. SI traceable means that you can actually trace it to concentration molar units. This is what a chemist can do with mass spec or really precise analytical techniques. In contrast, there are those categories of standards that are not SI traceable in arbitrary units, and they use the World Health Organization international units, and I'll expand on that in a minute. The Joint Commission, Joint Committee on Traceability has slightly different wording. Some assays are based on trueness, some are based on not trueness. I don't like to tell that to my relatives. My job is to create lab tests that aren't true, but immunoassays often come down to that. It's not, of course, I don't mean that they're not true, but we don't have that same degree of validity that we would like with a true gold standard. So who says that something is a gold standard? Well, again, the ISO group and the JCTLM able to essentially establish these gold standards. Other groups establish calibrators or harmonization techniques. And that includes IFCC, the International Federation of Clinical Chemistry. And the WHO does both. They are the only organization that can assign international units, IU designation. And some of their techniques meet these gold standards, and others are simply attempts for harmonization or the best we can do. And again, the common goal is to have consistent results. And if we have gold standards, use them. If we don't, we try to harmonize. It's actually sort of sobering. Out of the thousands of laboratory tests in a clinical laboratory, WHO has biological standards for about 350 that are assigned RU values. Many of these are infectious disease, antigens, and antibodies. But a lot of assays really don't have this degree of calibration or standardization. The WHO also has a lesser degree of calibrator, what they call reference reagents. This is a candidate or interim standard, not yet proven, may not be pure or stable or commutable, but we're saying let's throw it out there and see how it works. And that's available for ANAs. So this is back in 1982. The reference sera, again, this is not an IU standard, but a reference sera that was endorsed by the WHO Committee of International Union of Immunological Societies Committee on Autoantibodies Standardization. Don't say that fast. But the point is that the WHO got together with the US Centers for Disease Control, the Arthritis Foundation, and came up with standards that were appropriate at the time. They were mainly designed to say we want to have a standard for some of the ANA subsets, such as antibodies against DNA or the SSB or LA, as well as some for just immunofluorescence by itself. But they didn't have an assigned titer. They had an average titer and were given a range of titer. So how did that do? Well, it's been modified in a variety of ways since then to try to improve it. And the results is that pattern and specific autoantibody detection has improved, but I would say there's no real improvement in titer standardization. We don't have a method. So why is it so hard to standardize antibodies? Well, some of it relates to the biology of people and their diseases and their immune systems. Antigen targets and patient antibodies are very different and variable. And actually in the HEP2 cell, there are over 100 antigens that have been shown to be recognized by some autoimmune sera, one or more autoimmune sera. And so you can think about the ANA as the original multiplex assay. In addition, there may be different epitopes on the same antigen, and some of these can be linear and some can be conformational, so it's complicated. And patients often have multiple autoantibodies. And sometimes the standards are based on a limited source, so they're just not very representative of a general population. But part of the challenge is that there are other factors besides the biology. This relates to how the tests are done. There are issues related to the kits. There are system factors for how tests are ordered. But I'm going to focus more time and come back to issues in the clinical laboratory where pipetting and diluting, even the choice of the starting and ending dilutions, the use of the microscope and how they're done, staff training and procedures are all under the authority of individual laboratories and therefore under our control. So how can a lab harmonize or standardize in the absence of a gold standard procedure or gold standard for the titer? Well, this is a problem. And so the president of the European Autoimmunity Standardization Initiative, which is a group that started in 2006, it's not exactly giving up, but he says, you know what? The generation of internationally accepted standards and standardization has not been achieved. Harmonization may offer an alternative approach. The focus has drifted away from standards in favor of harmonization. And that's he published a couple years ago. So are there some examples in a clinical laboratory with good tests they don't have a gold standard for calibration? And I would say, yeah, there are actually several. One of the common ones is the prothrombin time. The solution was to generate an INR, International Normalized Ratio. We used to report prothrombin time. The results came out in seconds. It's now totally been replaced essentially by the INR in routine clinical use. Another example, and I'm going to now get to population harmonization and how population distributions can help harmonize an assay. And this goes back to AFP measurement in Great Britain. There were multi-center studies that were trying to evaluate the serum of pregnant patients, and they had very different AFP results. And the question is, how do we harmonize those results? And their solution was to harmonize by reporting in units of a population, not based on the assay itself. So this was their paper in 1977. This is the wording. A considerable, I can't do it with a British accent, but considerable variation in AFP measurements between different laboratories was evident. Each result was therefore expressed as a multiple of that center's median normal value at the relevant gestational time. So maternal serum AFP increases during the second trimester. What one would do is determine what the population in that given laboratory looked like, determine the median value independent of what the actual units were, and then generate the MOM, the patient result divided by the median result for that gestational age. And that's worked and continued till the present. Another way in which clinical utility is improved by population reporting is bone density, so not a laboratory test, but in radiology, where the bone density units measured by in radiology are actually converted to population units, which are then reported and used clinically. And the population units are the Z-score, the number of standard deviations from a mean of a population with a patient's age and sex. So the typical statistics use of the word Z-score. And they also had a T-score, the number of standard deviations from the mean of a population of healthy 30-year-olds. That is, this is sort of the gold standard of what bone density ought to be, young and healthy population. And so the results that get reported of bone density are not in bone density units, but in a T-score, that is the number of standard deviations from the distribution, based on the distribution of healthy 30-year-olds. And this is sex matched. And then there's also a report of the Z-score, that is, how does this patient compare with others of the same age and sex, realizing that the curves shift as patients get older and bone density decreases. So you can see how your patient compares with others of the same age and sex, as well as with the ideal population of healthy 30-year-olds. So my question, can a population approach standardize ANA quantitation? That's kind of what I want to think about. And the alignment target then would be a 1 to 80 titer, and we might be able to use the references in that criteria paper that I referred to you and showed you earlier to establish expected cutoffs. We differed from the ANA criteria paper because that one bundled healthy controls with disease controls to get that 25% false positive rate. And that's useful for estimating clinical specificity, patients walking into a specialist office, for example. But for a clinical laboratory setting a reference range, we wouldn't usually want to have disease controls, if you will, in the reference population. So we focused on healthy controls. And this came out of the immunology lab, published just last month. Lots of words here, but we're calling it calibration and harmonization adjustment via population interrogation. And here's the idea. We did a meta-analysis from that paper that was used to set ANA criteria, and we looked at all the studies that had healthy controls that were screened at 1 to 40 and 1 to 80. You can see that the specificity had a fair bit of variability, as you might expect, and what we already know from what I've described already. But we could do a meta-analysis and find out where they settled and what's the target. And that led to 1 to 40 dilution having a specificity of 79%. That is to say about 79.2%, about 80%, so 20% positive in a general population, 1 to 80, about 10% positive in a healthy population, 91% specificity with suitable sensitivity, as you would expect. This came from the same kind of study. So this gives us a target. The expected frequency of a positive ANA at a 1 to 40 serum dilution ought to be about 20%. And at a 1 to 80 ought to be about 10% in a healthy population. We're giving labs a benchmark. And then laboratories, I think, can reverse engineer and adjust their in-lab methods to achieve a target specificity with the local healthy population. And based on that literature review that we did, we kind of have a definition of what might be a healthy population. You could say, well, can a lab actually adjust their assay? Well, in fact, as I showed you, all those choices that labs already have, they already do it. They may not do it consciously, if you will, or with intent, but they're already doing it. The microscope illumination, filters, lenses, screening magnification, screening titer, all up to the individual choice of laboratories. A lot of variability in staff training. What are the criteria for calling something positive or negative? And kind of behind the scenes in the immunology lab, we've been doing this actually for many years under the direction of the supervisors and managers, particularly Kathy Hutchinson, Anu Chaudhry, Phyllis Daum, who've been the managers and the supervisors in the immunology lab, and we've kind of been doing this all along. Now, I would say we have better justification and background for choosing what the target should be and what other labs can use, and I think we might be able to achieve some harmonization through that approach. So the idea, again, now we're picking, let's say, that 80% positive rate, that is 20% false positive, identify, and then can we align these this way and achieve harmonization? That's the concept. How else can we achieve harmonization? Well, there are other approaches, I would say. We could gotta have a better standard. We still need to know what that standard should be. And so I'm suggesting this is actually a good target. And then if one has an endpoint calibrator or standard with an assigned titer, labs can essentially align themselves. That is not currently available. There are some commercial standards, if you will, or calibrators or controls, but none of them are really set up and calibrated in this fashion. I think if one were to do that, having a population-based calibration is a reasonable approach. I think there's also promise from automated microscopy, which is increasingly being used. The expectation, and actually what is seen, is that we get improved precision, but not necessarily harmonization. So looking at that original CAP survey, you would expect that the curves for the different kits would get tighter, but they wouldn't necessarily align. In other words, more precision, but still scattered around what might be the target. And that's actually what's seen. I won't go into some of the literature. There are also alternative technologies, multiple individual antigen tests rather than this multiplex ANA, and those are being developed and are used with expanded multiplex bead systems and arrays and other approaches for the uncommon antigens and situations. There are regulatory hurdles to establishing these kinds of assays, but I think it's going to happen, and it is happening. Probably complementary with immunofluorescence, but some of this will be replacing immunofluorescence and has been doing so already. But I think individual laboratories who are doing ANAs can approach this harmonization while waiting for better standards and calibrators. I think this 1 to 80 endpoint could serve as a calibrator, and that would be an initial step and might be one that could be proposed. That's where I'm leaving talking about ANAs. And what I would say, this is a work in progress. There actually is another meeting for the autoantibody community this summer on how do we approach standardization now that we basically, harmonization, now that standardization hasn't been shown to work so far. And this is one of the proposals I'd like to present to that group. And I'd be interested in feedback about that from all of you, either here in person or later after the presentation. I want to expand this a little bit to talk about pandemic antibody, SARS-CoV-2 antibody, standardization and calibration and harmonization, which has some of the same issues. So I think most people in this audience know what we can measure in a clinical laboratory. We measure antibodies against the receptor binding domain, RBD, or against the spike or the nucleocapsid. All of them respond to infection, but the vaccine response is measured by anti-RBD or anti-spike. There are a number of different quantitation methods. I'm not going to go through them. The point is they all are highly correlated except for the anti-nucleocapsid, which is infection only, but all the others are highly correlated whether there's infection or whether there's vaccine. There are differences, but my emphasis now is not necessarily on the difference in the methods themselves. They're all important. They are markers of protection, and actually antibodies themselves are mediators of protection. And there's a lot of evidence for that. High correlation of antibody level with protection, high correlation actually with the type of vaccine from the different vaccine sources, as well as with the different virus variants. So this is a summary paper published last month with anti-spike, IgG, on the x-axis and the vaccine efficacy. The different colors reflect the different vendors of vaccines. The different colors represent the different variants of the virus, and the indicators in words indicate the different sources of vaccination. And there's really remarkably close, not perfect, but remarkably close correlation between protection and the levels as measured by anti-spike antibodies. And this is true for multiple vaccine types and viral variants. Another piece of evidence, I would say, in favor of the importance of antibodies is they're effective therapeutically. We can treat and prevent infection by giving therapeutic monoclonal antibodies. And another clinical argument is that if you don't have B cells to make antibodies, if you get COVID-19, it's likely to be very sick, make people very sick. So I'm not saying there's no role for T cells and innate immunity and other factors, but antibodies are really critical and important. And in fact, this paper that was the first issue of Science this year, published primarily from the Hutch and the UW, Larry Corey here is one of the key authors, as well as others, really looked at the Moderna vaccine and looked at breakthrough infections in vaccinated individuals. And what they found is that antibodies measured by all these various techniques, neutralizing anti-spike, anti-RBD, following vaccination, all correlate with protection from COVID infection. And the goal for this study is to provide a faster way to get new vaccines. If we had an antibody level that we knew was protective, we could measure one vaccine against another rather than waiting for large clinical trials. It's not clear that this information has really any use for advising individual patients, really not designed for that purpose. But it is, this is the data from that paper showing cases, that is the breakthrough cases, patients who were vaccinated but still got COVID versus non-cases, and anti-spike antibody at day 57 after vaccination shown here, neutralization shown here. And there's a statistically important difference between the two, but also lots of overlap, no matter how you measure antibodies. So although there is a calculated for protection of a population, there's no reliable threshold for protection of an individual. Again, this is from their paper, days since from day 57 visit. The key issue here, of course, is how remarkably effective vaccination is, right? If you get a placebo, this is the rate of infection, and this is the rate of infection if you have a high level of vaccine, middle level of vaccine, or a low level, vaccine, but antibody response. So substantial protection at all levels, but different levels depending upon the level of antibody. It makes a difference. And this has been summarized in other papers as well, looking at other assays and other vaccines. And one of the points of this paper is the correlations between antibody assays that all show protection, whether you're looking at spike versus RBD, which has, as you might expect, a very close correlation, or other measures of different antibody assays. But are they standardized? And there is a WHO anti-SARS-CoV-2 antibody standard that was prepared in 2020 from a pool of 11 convalescent plasmas that were assembled in England. There is some international IU status, but also binding activity units for binding assays such as ELISA and so on. And these are available from the usual source for WHO standards in Great Britain. How effective is it at harmonization of all the assays? And this is from a paper just published last month noting significant differences between commercial assays despite conversion to the WHO binding activity unit, the WHO unit. And the slopes between assays vary between 0.5 and 1.1. Not bad, you'd say, but you can see there's substantial differences in some assays, more concordance in others. And they conclude these results underline the importance of BAU conversion for comparison of antibody titer. That is, it got better if you did that conversion, but significant differences persist. You can't convert one assay result to another assay result, even if you have this common BAU unit. And this is from their population distribution showing statistically significant differences in populations depending upon the assay used. Here's another paper looking at the same sort of incomplete correlation between the Roche and the Abbott, between the Roche and the Diasorin, and between the Roche and Syrian assays. And this paper, published at the end of last year, our findings, I'm quoting here, our findings suggest that although all assays showed good correlation, the results were not interchangeable. even when converted to the BAU using WHO calibrator. This highlights the need for further standardization of SARS-CoV-2 serology. And here's another paper, similar story. All the assays correlated, but they differed. Can we use population-based harmonization? And I want to turn to a paper that came out of our lab in the early days of the pandemic from studies done actually at the very start by my colleagues in the immunology lab and Andrew Bryan in microbiology, and headed by Marie Das, who was who was the resident rotating through immunology at the time. And this was kind of a wild time. There were no approved or authorized assays for antibodies. There were no standards except what came with each kit, and actually some came with no standard. They just said measure ELISA and see what you get, kind of thing. The commercial assays were unvetted, they were variable, and early on we said, how do we standardize and compare with each other? And we did it by converting to z-scores. Results that were highly different from each other by their own internal units could be harmonized to some extent, and actually also allowed us to compare them better with each other. So if we didn't convert to d-score and just used OD or others, some assays looked like they had very, very flat curves and didn't have much of a slope at all. And by the way, what this is looking at patients who seroconverted while they were in the hospital. That is, they developed SARS-CoV-2, a COVID infection, they were hospitalized, we looked at their residual serum, and as a marker of sensitivity, said when did they get above the threshold. So we determined the mean and the SD of a population of pre-COVID donors. Why was that important? In these early days, we were very concerned about the possibility of coronaviruses that were causing upper respiratory infection and the common cold. And there was a lot of concern that the antibodies against SARS-CoV-2, the assays for antibodies against SARS-CoV-2 would also lead to false positive results in patients who had recent upper respiratory infections with community coronaviruses. We measured the antibodies also in these recently infected patients, and we looked at the time and the degree of seroconversion. But we could look at these assays that looked like they were relatively flat, but if we converted to a z-score, you could see that it actually had a pretty good slope, as good as those that you would at first glance not have appreciated to be a good test, because there's this trade-off between the sensitivity and the population distribution. And so we could account for the sensitivity and specificity by converting to z-score and normalize results that would otherwise be hard to interpret. And then we actually continued to follow up on this notion, looking at antibody measurements in convalescent plasma donor. This was worked on with the Infectious Disease Division, where we looked at neutralizing antibody titer compared with one assay for anti-spike, neutralizing compared with another assay for anti-nuclear capsid, and then comparing each with each other. And if we didn't convert to z-scores, these would be widely different, but these are uncommon z-score units, if you will, standard of deviations above the normal range. And there's a reasonable correlation. Not perfect, and you don't expect it. These are measuring different things, but it's a way to do a comparison with each other. And this is another, I think, useful paper to look at this kind of issue. One of our previous, while Ben Bradley was a resident working on this project, primarily in the virology lab, looking at concordance and concordance of the new anti-spike antibody that was being developed in the lab. And there are a lot of jewels in this paper, I would say, but one of the things they did was they took a population-based approach for comparing assays. So they had the Abbott Advice assay, the Roche Alexis assay, their immune assay. All of these are anti-spike antibodies, purportedly measured the same things. And they looked at what were the median values in immunized patients at various time points, the 10th percentile and the 90th percentile, to see if they can get a comparison over the course of development of antibodies. And this population approach actually allowed some degree of harmonization, even though the assays gave very, very different units. So it raises the question, could a population-based percentile be part of the report and help harmonize reports? This is another jewel from this paper. Actually, the first report that there's substantial overlap between the protective levels of antibodies and those who are at risk. So this is an interesting paper working with patients recruited primarily by Ann Jarris, who was industrial physician in charge of the fisheries fleets that go up to Alaska, wanting to prevent the development of COVID-19 in these small Alaskan villages. And she helped working with the department very closely to look at patients going up, and found that one boat, everybody on the boat got COVID except for these 3 individuals. And this was the level of antibody on the ADVISE assay in AU units. And in contrast, these were healthcare workers who had been vaccinated and still developed COVID. And looking at the units of in the ADVISE AU. And one important message here is that there's overlap. You can't tell who's protected and who's not. But what I want to present this for also is to show how even the attempt to convert to international units per ml and harmonize the results between these 2 assays didn't work very well. So IU 1700, IU 471. If you look at the correlation of these by the AU versus, the ADVISE versus the EU, this is the correlation, this curve, and it obviously is not perfect. If you convert to population percentile distribution, it looks more like this. Still not perfect. And these are obviously very limited numbers and very preliminary. But this is the approach that I think might be used to harmonize essentially unstandardized units, and maybe something that might be effective. So the idea here is you wouldn't just pick one point. You'd really have to look at cut points at various levels of a population. And you could use calibrators collected from vaccine trials, for example, for standardizing this. Reagent manufacturers could determine their assay results at various population percentiles. And the idea is that you'd kind of align them, not by normalizing their units, but by normalizing or adjusting their population distributions. That's the idea. There are a lot of reasons why antibodies are not harmonized. I'm not going to go into all the reasons. It relates to the antigens, to the antibodies, to the platforms, and also for the indications. And again, I want to talk about, SARS-CoV-2. Vaccination certification by the WHO has one need. If there's going to be clinical use, it has another set of needs. Even for ANAs, specialists who want high sensitivity have a slightly different perspective than primary care docs that really want to prioritize specificity. But is there a use for antibodies in populations? And again, we don't have indications for that now, but here are data published last year about essentially lack of seroconversion in cancer patients. On the y-axis here is anti-spike antibodies in different groups, controls, hematologic malignancies, and solid tumors. And among the hematologic malignancies, there is really the most lack of development of antibodies, but they're very heterogeneous. There are some patients who develop no antibodies after vaccination, others that get essentially normal and high levels after vaccination. And the current guidelines don't account for this individual difference. From a population perspective, the advice for extra boosters and for preventive monoclonal antibodies, all these people are lumped together because we're not measuring antibodies and we don't have them as a marker. There's also a lot of literature about the high association of B-cell depletion, for example, with rituximab, anti-CD20, as being a major cause for the lack of antibodies. But B-cell depletion due to rituximab is transient. And when the B-cells come back, patients can respond. So if you don't have timing involved and don't measure the antibodies, you wouldn't know whether or not a patient has their antibodies in response to vaccine or not. So there may be, I would say, some reason to think about this in a clinical setting. Important message now, though, there's no guarantee against breakthrough infections based on antibody titer. The level of antibody associated with the population immunity and protection is probabilistic, not absolute. If you don't have antibodies, however, for example, if you immunize when you have no B cells, the risk goes way, way up. And the question is, would antibody measurement be helpful in evaluating modestly or transiently immunosuppressed populations? Not the severe immunosuppressed, but for example, patients with autoimmune rheumatic diseases that have modest degrees of immunosuppression. I would say this is not now, but in the future, it might be something that's useful, and if so, will require harmonized assays to implement this clinically. So some implications of this, I would say let's consider population-based calibration approaches when there's no high-quality standard available. You can compare with a healthy control population and the Z-score approach that we took in the early days of the pandemic. In thinking about this, for COVID-related tests, we're not going to have seronegative patients coming to us anymore. So if that is a useful thing, we ought to start saving pre-pandemic, pre-2020 plasma and serum because we may want it for this comparison kind of study. For healthy immunized populations, we might be able to provide the percentiles of that healthy population for one or a few effective vaccines. I would say all this is temporizing. If there's good harmonization and effective standards through calibration of assays, that's the best approach. But in the meantime, a population-based approach, I think, might be reasonable. So, summary, standardization is challenging for a lot of reasons. That's despite attempts at standardization, such as with the WHO standard. And for ANA, I think population calibration can be helpful. And it's been used in the immunology laboratory for a number of years. I think it can be refined now. I have a lot of thanks and acknowledgments. Some of these ideas have been percolating for many years in the lab and by colleagues who I've had these discussions with. Mike Aston years ago got me to think about ANAs and in a standardized way because of our attempt to develop, actually at that time, an automated system. I already talked about Andy Hufnagel criticizing me for being an immunologist and immunoassays imperfection. Not really, but imperfection. We all owe a debt of gratitude to Alex and Keith, and some of the studies that I referred to, including those from Ben Bradley, involved their lab. None of those folks were involved with this talk or this concept, but I really want to thank them for a lot of their work. Immunology division staff does ANA testing, and I wanted to show pictures of them masked and unmasked. But a special thank you and appreciation to the lab managers and supervisors, Anu Chaudhry, Phyllis Daum, and particularly Kathy Hutchinson, who over many years have done this kind of standardization, others for the clinical laboratory. And Kathy was instrumental in developing the ANA computer program that's widely used around the country. And actually, in gratitude to Kathy and Phyllis for their many years of being the director of the immunology, of the supervisors of the laboratory, we've established Hutchinson, Daum, Endowment in Lab Medicine for continued education and specialized training for lab managers and supervisors. And that's been established at the UW and publicly announcing it for the first time today. So again, I appreciate your interest and comments and look forward to feedback either today or informally at some future time. So thank you for your attention and for being here either virtually or in person.
Mark, that was great. I'd love the harmonization of the ANAs versus the standardization. You talked about the reference sera that's decades old. How would you make it today? What would you do to make a calibrator for ANAs?
Yeah, great question. So how would we make a calibrator today that would work? And I might also say, are there any candidate preparations that I think might actually be useful? So we actually had the opportunity of being involved with making what's called a mega pool, combining sera from literally pools that got pooled, and ultimately thousands that are making antibodies, ANA for a particular autoantibody that's common in the population. So the dense, fine, speckled ANA is the most common, if you will, false positive. That is to say, present in the population, causes a real ANA, but not associated with clinical disease. So I think because that's relatively common in the general population, about 5%, I think labs could actually use that to standardize their assays with a titer and confirm it with their local population. So I think the idea of having a large pool of a defined titer from multiple individuals, so the individual sort of private antibodies, and then it needs to have an assigned titer, not of this can be this or this, because then that's too much latitude. And I think that would work. Again, a related approach is to say, let's come up with a 1 to 80 endpoint calibrator. Let's all agree that whatever the technique is used in the lab, we're going to define something with a calibrator that's got an endpoint. Up until now, we haven't actually known what to do. And I'm saying I have a suggestion for what to do and how to approach it.
So
Thank you for your question.
Different patterns don't matter?
Oh, patterns make a difference. So one of the reasons to use that dense fine speckled is it's common. Almost all conventional immunofluorescence vendors pick it up with similar degree. So that isn't true for all assays, for all antibodies, but this is one that's relatively homogeneous. That would need to be formally tested, and this mega pool of anti-DFS, anti-dense fine speckled, has actually been tested by multiple laboratories reporting their individual results. There wasn't an attempt to harmonize. It was given as a survey, rather than as a prescriptor. We would have to redo that kind of stuff. And we actually had the opportunity, of being one of the labs asked to evaluate that. And it does work. But again, we were told, tell us what you saw, not use it as a calibrator. But I think it has that potential. Thank you for a good question. Again, thank you all for coming and for being out in a crowd or virtually. Thank you very much.